very actively involved in CCSVI. Manny's an associate professor of surgery at Albany Medical College. He's director of the endovascular services there, and he has treated many patients with CCSVI, over, well, hundreds, and is very active. And I wanted him to share with you what's been going on with his trial and his experience, so you'd have a look at that. But I think this type of information, like was shared today, is the one thing that will open doors. And once we get rolling on getting true collaborative trials, which is the absolute goal of this, because obviously the main expertise in MS resides in neurology, no doubt about it. We just have to sort of get some proof and legitimacy established, and then it's going to start to roll. It really is. And so, Manny, come on up.
Sorry, I'm a very dear friend, and I've learned a lot from him. And truly, just to backtrack a little bit, what Sharon Richardson and CCSVI Alliance has done is really remarkable, from what it started to what it is. So I really do want to applaud it. As I get started, I do want to tell you a little story. So in January of 2010, I probably knew very little about CCSVI or MS for that matter, until a patient came in through the door and said, "Listen, Dr. Mehta, you came highly recommended and we want you to fix my husband's veins." And I kind of said, "I think you're in the wrong place. I'm a vascular surgeon, but I don't know anything about MS." And she convinced me to look it up, study it and all that, and 2 months later we treated him, and he was a Navy SEAL who was completely, to use the word that he described himself, was hopeless and pathetic in the way he acted, and the response was so positive that, and my research team is sitting back there, and all of them are here, we kind of put our heads together and we said, "Look, we got to look at this a little differently." So I'm going to share some stuff with you as to what has evolved from that research, and talk a little bit about what is my understanding of CCSVI and MS from somebody who 3 years ago, 4 years ago, knew enough about MS to pass the tests that I needed to become a doctor, but really my focus was not on that at all. So in looking all this up, and one of the incredible things about this, and I think one of the things that has brought Mike and our friendships even closer, is when this patient came and she asked me to treat her husband, the first person I called was Mike, because I knew he had treated some, and he was kind enough to share his thoughts and stuff, and I actually visited Zamboni and we collaborated a little bit. And it's really through these small steps that we have been able to even get here. So as much as it seems like there are a lot of building blocks, it's really amazing how far we have come in such a short time. So, multiple sclerosis, and just a little something on it, is nothing new. Really, it was 14th century when the symptoms were first discovered. No one really knew what it was. And Charcot in 1968 really put the dots together in connecting what MS is to the diagnosis of MS. And then, another century later, not much is going on. People are trying to figure out what it is and what it is not. But it was a neurosurgeon by the name of Tracy Putnam who actually did a study in dogs, and he ligated the jugular veins of the dogs. And after they were sacrificed, some time later, he looked at the brain lesions, and he identified similar types of lesions in canine models. And he actually wrote this down, and he says maybe this is an antecedent. But of course that was lost, and these are small reports that come up, and there are thousands of scenarios like this that people sometimes pay attention. Sometimes there's a CCSVI Alliance that has the energy to push these causes, and sometimes they're just lost in the shuffle. And since then, over the decades, it has really gone on to say, well, MS, is it an allergic phenomena? Is it an autoimmune phenomena? And the reality is we just don't know. We know that the etiology is multifactorial. We know that there are a lot of things that could cause it. Is there genetic predisposition? The answer is yes. Is it multivitamins, smoking? I've seen bar virus. All these things have been implicated to one degree or another. We know that there's axonal damage, and this precedes the autoimmunity that gets started. We have that sense. MS plaques are mostly venocentric, so there's this tiny vein in the center of all these plaques that is becoming more and more discoverable today because we have incredible imaging. 10, 20 years ago, we didn't have this imaging, so we could not. It's kind of like not having a microscope for trying to look at germs. You can't find them, but once you look at these things under a microscope, it becomes all too obvious that what's there or what's not. And certainly the new data that's coming out and the new trends in what we're trying to identify is that there is an absence or a diminished cerebral perfusion with these. And there are those three things that clearly, the etiology, the MS plaques being venocentric, and this cerebral perfusion that is globally diminished, that might play into or tie into CCSVI. We also know that there is really no cure, and we know that this affects the motor, somatosensory, cognitive. It really affects a whole host of things. The differential diagnosis is vast, and that's why sometimes it takes years before MS is really discovered, and there certainly is no cure. And then treatments, sometimes they work, and that's great when they work, but sometimes they don't, and some patients can't tolerate it, and a lot of them are immunosuppressives. Obviously, Paolo Zamboni in 2009 came up with this, and I think Ray's already touched on this, but essentially what it is a central vein stenosis that can cause backage of blood within the central nervous system, and this chronic stasis and regurgitation of blood can cause the red blood cells to move out. Now what happens, and we know this very well through many, many years of histological evaluations, when the red blood cells are stagnant against the walls of the veins, they grab onto them. They really have ability to do that. In other words, they're round, but when they're stagnant, they latch on, and there are these junctions within the innermost lining of the veins that can hold on to that, and it's possible that that's where the red blood cell can escape, and once it escapes, it certainly doesn't have feet that it can run around, it just sits there. Once it sits there, most of it is absorbed, except for certain parts of it, and one of them is hemosiderin. Hemosiderin is iron, and that is how red blood cells carry oxygen that comes from the lungs. The iron traps the oxygen and is delivered all over the body, but when it's trapped, it's functionless, except that the iron sits there. And maybe it's the iron that causes the inflammatory response, and that's really what the theory is. Now, the reason this is becoming more and more understandable, and I think we have some experts here in imaging, and we'll learn some more about it, is that with the diffusion weighted susceptibility images, we can tell, we have 6-7 Tesla MRs, which can look into the brain much more clearly than we were able to do 10, 20 years ago, and that certainly has had a big impact in how we identify this. So the quintessential thing that happened was when Zamboni in 2009, and he had been working on this for years, it's not that he just in 2009 came up with this idea, but he certainly published this in 2009, 65 patients, internal jugular veins and azygous vein angioplasty for stenosis more than 50%, and he measured quality of life and functional composite scores, which are both MS functional composite score as well as MS quality of life are well accepted standards in neurology community, long before we came into this Dr. Dake, Dr. Zamboni, myself, and many others have come into the arena and saying, let's treat this disease and try to see how we can quantify it. These are the tools that are well accepted within the MS community. There is some subjectivity and some objectivity to it, but these are the tools that we have. And in looking at that, he clearly, can you go back one more slide? Yes. He clearly noted that at 1 year there was a significant improvement in these patients, particularly relapse remitting. And the reason sometimes that was more obvious than not is because the secondary progressive, primary progressives, the numbers were much smaller. Now, maybe it has a difference, maybe it doesn't, but we know when the number shrinks, it's difficult to show statistical bearing sometimes. Following that, the neurologist, Dr. Zivadnov, established secondary or other correlations in that he did a randomized study which was blinded. He looked at 500 patients with transcranial Dopplers and ultrasounds to see what these lesions could look like. So he essentially took healthy controls as well as MS patients and patients with other neurodegenerative disorders, and he analyzed them. And what he found in comparing 280 MS patients to 161 healthy controls is that MS patients, if you had MS, there was over a 50% chance that you had central venous stenosis. If you did not have MS, or no diagnosis of MS, and you were considered healthy, then there was about a 20-25% chance that you might have a blockage in your central veins. Now, having said that, ultrasound is not necessarily the best test, but it is a start. It's a non-invasive test, and there are these criteria that Zamboni defined, that if you have 2 of those criteria or greater, then there's a significant chance that you can have CCSVI. Now, what are the other evidence? And these are reports that are just coming out. I just reviewed an article for the European Journal of Vascular and Endovascular Surgery, in which Zamboni and Zvardmir put their efforts together, and they evaluated 16 patients with MS versus 8 patients that were healthy controls. And what they found is that MS patients fulfilled the diagnosis of CCSVI, and none of the healthy controls fulfilled the diagnosis of CCSVI. MS patients had a higher iron deposit. They looked at central nervous system with susceptibility-weighted imaging, very sophisticated MRs, and there was a significant associated between CCSVI parameters and increased CNS iron concentration. versus the healthy controls. So there is a pendulum and a movement that's coming in one direction, and I agree with you, Mike. You know, when we hear these crazy stories about, you know, this is just terrible, it makes you somewhat upset, because we're looking at evidence and we're simply trying to follow what the evidence shows us without having hyperbole about anecdotal reports. So what has been published, and a lot has been published actually, and I'm glad, Sharon, that you're going to put this together. And I'm going to share just some of it with you, the things that are pretty clear, and that is 6 published reports on angioplasty of jugular veins and esophagus veins. Altogether, 988 patients that have been reported already and published in literature. Of these, major complications, 0. Death, 0. Minor complications, less than 2%, and the minor complications are when you have a little bit of a hematoma in the groin, you have some oozing that can come from the catheters that we put in the groin, or people have headaches, or sometimes about 1 to 2% of people can have arrhythmias. They're usually transient, and we go through from the groin, through the heart to get to the jugular veins. So normally when you take the wires and the catheters out, these arrhythmias tend to go away. But it is possible that if somebody is predisposed to them, that can become a, you know, long-term problem. But it's still less than 2%. How about stenting trials? Now in US, this data comes from out of US, because in US this is not something that we're really trying to study. And 2 published clinical trials, over 500 patients, nearly 545 patients. Minor complications, once again, less than 2%. Major complications, none. Death, 1%. Well, I mean, 1 patient, 0.2%. Obviously not a good thing. None of us doctors want to see anything bad happen to our patients, but it's not necessarily MS. There are other complications that can occur from any procedures. I'm a surgeon. I operate on patients all the time. And when I operate on their major blood vessels in the abdomen, my biggest risk is that they're going to die of a heart attack as a secondary complication, even though I never touched the heart. So, you know, there are risks when you have to do any kind of treatment. But still, the risks are fairly minimum. And if this was evidence that was emerging from many different sites and it was reproducible, no one would argue. And today, the Western IRBs, and even I would assume that even FDA, looking at the reports that are published, would say that this is a low-risk procedure, and you can't argue that. But there's still a lot of confusion and a lot of controversy, and obviously, you know, we've already talked about it in the first 3 speakers that were here, and it's very frustrating. And there are problems because we don't have a good tool to simply say, put a probe on the neck and say, oops, you got it, or you don't have it. The ultrasound varies. You know, there is some subjectivity, or a lot of subjectivity in ultrasound, so it depends who's doing it. People who are good at doing ultrasounds get better and better, and people that are not might not. But still, I suspect maybe the best we'll reach with an ultrasound looking at veins could be 60–70% accuracy, maybe 80%, but it will never be 100%, because ultrasounds never do that. But they give us a light into the window of, you know, what's going on. What about treatment? And, you know, Ray talked about this a little bit. There's no standardized way of treating it, and we're all the doctors like myself that are trying to treat patients, we're taking baby steps, right? Do no harm, do simple things. Just dilate a balloon, be conservative, but make sure you treat the lesion. And Mike and I talk about this often, you know, because we're not even consistently sure when we have fully treated or not treated. But if I had to flip a coin and make a decision, I would be more conservative in just backing off. And if that patient doesn't necessarily see a benefit, do we say it's a failure? Well, not really. Maybe I just didn't fully treat it because it is early in the treatment as we're moving along with this. So to add to this confusion and controversy, I said, you know what? What's the best engine I know for searching today, right? My 6-year-old will tell me it's Google. So I Googled every possible thing that was written about CCSVI and MS. A lot of it is good. A lot more is nasty. So let's just kind of sort through this and what's going on. So of everything that is written, and there are about 53 reports out there, or anecdotal things, or commentaries, less than 20% of them are really evaluating science. 80% or more are simply evaluating somebody else's data and saying, you know, I don't like the way those findings came out to me. So I figured it was probably important if we look at evidence. And we actually have generated significant evidence. This has been presented just a few months ago at the Society of Vascular Surgery. It's been published in an abstract format, and we're actually in the process of finishing the manuscript right now, which will be going to JVS, Journal of Vascular Surgery, which is one of the major publications for vascular surgeons. And they are desperately awaiting this, as a matter of fact. And they keep calling me and saying, when are you going to get this ready? Unfortunately, Mike has gotten me so busy with VIVA that I haven't gotten a chance to pause, but we're getting there. So this is really a prospective, randomized trial, double-blinded, but it has many things that are going on with this. So it's a prospective study which is looking at 600 patients, 400 will get treatment, 200 will get sham. In other words, they will not get angioplasty. They will still get a venogram, but they will not get an angioplasty. Whether you are sham, in the sham arm or in the treatment arm, you do not know what you had. You get sedation during the procedure. It's pretty heavy. You might think you had it done, or you might not think you had it done, but really nobody knows. The neurologist doesn't know, and even our coordinators and nurses that evaluate the patients do not know. Only a select few people who are involved with the procedure know. So that's really the way you can do that best clinical trial if you wanted to. Now, I'm not saying that this is something that we absolutely need. Now, the purist in me wants to do this. The realist in me believes what Mike has been really advocating for a long time. We need to move the pendulum in a direction. And you know, to be honest, none of us want to waste your time. None of us want to hurt patients. And none of us certainly want to waste our lives for the next 10, 20 years focusing on this if this really doesn't have value. So I think we need to create some sort of evidence in one direction or another. So one of the things we were able to do through Western IRB is to convince them, and they actually suggested we do this, and that is to go down a path where we have a longitudinal study. And what that really means is as you're treating patients, you have the ability to collect data, and you cap it at a certain number, and we wanted to cap it at 100, and then you can look at that evidence in a very constructive way. Even though it's collected somewhat retrospect, in other words, patients are treated and then you're collecting it, we collect data prospectively. We collect it as we're treating people and as we're following patients. So this data, although this arm is a retrospective study, all the data that comes through it is essentially prospectively collected. So what we did in patients is a venogram. We treated patients similar to Zamboni did if the narrowing was more than 50%. Standardized approach, same approach for everybody, and angioplasty only. We also have recently added a prospective arm to take a look and do venograms on normal subjects. And I was really proud of the fact that my partners volunteered and said, you know what, we're going to get this done, and we're in the process of getting venograms at Albany Vascular Group in normal subjects. Those are vascular surgeons that are practicing. It's not going to be Ray for sure, but they are other vascular surgeons that are practicing. So, and what we looked at is really clinical evaluation as we follow these patients. 25-foot walk, which is an objective criteria, well accepted by MS societies and organizations, and MS quality of life, as well as modified fatigue impact scale, which are also accepted, but they're more subjective criteria. So let me go through this a little bit, and I'll move a little quick. 62% of the population are women, which is generally what it tends to be. Mean age is 47 years. Relapse remitting in a little over 50%, secondary progressive in about 1/3, and about 12% primary progressive. These are the patients that have been treated. Now I'm going to show you these images. That's a venogram, and that's a venogram. They're both looking at the left internal jugular veins, and you might look at this, people who don't see this all the time, and say, well, I'm not sure. Is one abnormal or one not normal? If I don't have, I do. That's good. If you look right here, where the hand sign is, you can see, thank you.
Here's the laser tracer.
Oh, thank you. If you take a look right here, look what's happening. Remember those valves Ray was describing?
Yes.
Look how beautifully they're working. This is a normal patient. This is one of my partners, venogram. Look at the other vein. Valves here are a little bit more difficult to appreciate, but they're working, and look at the empty. This is what we see in normal subjects for all of us who treat these patients. This is not normal. It's pretty clear, right? That's not normal. So these are the patients that we end up treating with venoplasty. We take that balloon, we angioplasty. We clearly see that wasting. That wasting sometimes takes a lot of effort to open up, and that is the balloon that's fully dilated. And that's it. Can you go back a slide, just? Can you go back one more? So this was this patient before angioplasty. That vein is not emptying until that fully distended. To this after treatment. Much different, right? Look up here what happens. This is only, the valve is not here, but look at the shape the contrast takes. And you know what that tells you? The valve down here is working in that ability, and the valve functions come back. Maybe they're stiff valves, maybe they're stenosed. But it's pretty clear that by dilating, by just jarring it a little bit, we certainly, or we might get some of that function back, pre and post. And that's that's a patient we treated just I think a month ago or something like that. So clearly there is a difference in normal and not normal, at least what we are seeing. Total lesions 174, 41% in the right side. I'm sorry, this is off a little. 49% on the left side. Jugular veins in the jugulars, the azygos accounted for about 10% of the lesions, and that's what you see when you really see that. Although not all jugular veins are that clear cut, and sometimes it's really difficult, and sometimes it's a judgment call. But when you see veins like that, that's absolutely not normal. So looking at these patients, average 1.7 lesions per patient is what we found. 22% had only one lesion. 50% of the patients had 2 blockages somewhere. 20% of the patients had 3 blockages, and there are other patients that had more than 3 blockages. Maybe blockage lower in the jugular, higher in the jugular, and azygos and other places. What do? We anticoagulate the patient during the procedure. We always give them antiplatelets following the procedure. There's no clear regimen for this. And we count a success if you do not have a residual stenosis of more than 30% that's left. So in looking at this, the mean follow-up, and we've had this in 79 patients, so a little over 4 months, restenosis of more than 50%, only in 8% of people. Occlusion, only in 2% of people. Other complications, and this was one patient that had that arrhythmia from the water that went in and tickled his heart, and in 2 days it went back to normal sinus rhythm, and nothing has recurred, he's doing well. Major complications, 0. Death, 0. Relatively or very safe procedure. Let's look at some of the other outcomes. So we were measuring that 25-foot walk, and in looking at all MS patients, pre-procedure, post-procedure, statistically significant difference. If you look at relapse remitting type, there were 53 patients, pre-procedure, post-procedure, statistically significant difference. See, the difference is small, but when you have this many patients having an impact on that, that tells you whether it is statistically significant or not. If you take one patient and improve his walking distance by 10 seconds, that will not be statistically significant. So it's not the number, it's the p-value here that really tells us whether we are in the right direction. Secondary progressive, these are patients that could walk, statistically significant difference. Primary progressive, only 6 patients, but these were patients that could walk, statistically significant difference. Unbelievable. I mean, we were shocked, I'll be honest with you. I did not expect this as we were doing these analyses. MS quality of life analysis, and these are mean numbers, but this is physical health composite score, before, after, significant difference. If you look at mental health, before, after, significant difference. If you see a number right here that is less than 0.05, that is significant, and that tells us statistically that this matters. Modified fatigue impact score, statistically significant improvement along all those categories. So the next question for us was very obvious. How many patients are getting better? 80 to 92% of patients report improvements in these treatment modalities. Not everybody does. And I can tell you this is our bias. As I'm evolving through it, I can tell you that I have treated patients that I've walked away saying, I don't think I want to hurt them, so I don't want to dilate that balloon too much. Maybe, and earlier in my experience, I was not doing what I do today. I've certainly learned a lot in the last few years of treating hundreds of patients. If you look at the symptoms, so we analyzed what symptoms were really improving. Now, this is not something that is accepted by MS organizations and societies, and nor do I expect it to, but we wanted to know, what do I tell my patients when they come in? Doc, what's going to get better is the question they ask me. And I have no way of telling them unless I look at symptoms individually. So we looked at loss of balance, lower extremity weakness, bladder incontinence, decreased coordination, and vertigo. So this is how many patients, percent of patients reported these problems to be true. This is how many patients improved. About 2/3 of all the patients we treated with these problems showed statistically significant improvement before and after. What about other things? Fatigue, heat intolerance, memory loss, depression. Once again, 2/3 of the patients reported them, and 2/3 of those patients reported significant improvement. Now, this is not one patient that has everything that's gotten better, but this is, patients that have certainly seen one improvement over the other. So let's come back to this, and this was probably the most important thing of me doing that Google search of that 53 reports I found. Less than 20% evaluated evidence really for or against CCSVI, and that's what we want. let's look at studies by specialty, and this is why this is such, there is a need for a multidisciplinary approach and, an effort. Mike is an interventional radiologist, I'm a vascular surgeon. I've learned an incredible amount from Mike in my evolution of this, and vice versa are the things that need to occur as we move forward. Surgeons and interventionalists, when they study these things together, and any CCSVI report that has been published by surgeons or interventionalists who do these procedures, they've been positive. If you look at neurologists, in a small center studies, this, which are I think only 2 where they looked at ultrasounds only, and single center, if it's neurologists alone, the studies have been negative about CCSVI. Nothing against neurologists, believe you me, I want their help because I need to learn this disease better to take care of our patients and my patients. When you look at large randomized trials in which the neurologists participate, remember Zamboni, the neurologist we talked about from Buffalo, and I was really excited to hear what Mike was saying, the neurologist from Cleveland Clinic that is looking at these, unfortunate but autopsy specimens. When they look at this prospectively, even neurologists find this to have a favorable outcome. When you look at any collaborative effort between neurologists, interventionalists, surgeons, the findings of all these things have always been positive. They're moving the pendulum in a direction, and it's all positive towards what CCSVI is and what we are understanding. So the scientists in me want to put this together, and I said, look, preliminary data suggests that MS has a significant association. Everything is pointing in that direction. Venoplasty for jugular veins and azygous veins is relatively safe. Today, we certainly have more questions than answers. We certainly need more data. We certainly need more studies. We need a lot more people involved. We need CCSVI alliances, and we need a lot of people that are affected by it, or families and friends, to take a very active role. And if I've gotten a chance to get to know an MS patient through the chat boxes and websites over the last couple of years, I am sure we're going to reach this goal together. Once again, I want to thank CCSVI for putting this together, and Mike for taking such a leadership in helping all of us developing therapies about this. Thank you.